Selamat pagi, good morning, honorable guests, esteemed speakers and panelists, colleagues, ladies and gentlemen, everyone joining us both on-site and virtually from across East Asia and the Pacific and from around the world. Welcome to the launch of the World Bank's new publication, A Healthy Future, Primary Healthcare and the Chronic Disease Epidemic in East Asia and the Pacific. My name is Claudia Lenke, and I'm delighted to be the MC for this occasion. Before we begin, allow me to extend a warm welcome to all distinguished participants joining us today. His Excellency Budi Gunadi Sadikin, Minister of Health, the Republic of Indonesia. Caroline Turk, Division Director, Indonesia and Timor-Leste, the World Bank. His Excellency Abdullah Salem Al-Daheri, Ambassador, Embassy of the United Arab Emirates. Professor Ali Gufron Mukti, President Director BPJS Kesehatan. Mr. Aditya Matu, Chief Economist, East Asia and Pacific Region, the World Bank. Ms. Karen Bredenkamp, Practice Manager, Health, Nutrition and Population, East Asia and Pacific Region, the World Bank. Ms. Beverly Ho, Chief Health Officer, Ayala Healthcare Holdings, Philippines. The Directors of Development Partners, Private Sectors and Universities. The DGs and Directors of the Ministry of Health and relevant ministries. Ladies and gentlemen, without further ado, allow us to begin our program. Let's start with the opening remarks from Caroline Turk, Division Director, Indonesia and Timor-Leste, the World Bank. Carrie, the stage is yours.
What is really a shared challenge? How can we build health systems that help people to live longer, live healthier, and live more productive lives? Indonesia is a fitting host for this important launch. Indonesia is pursuing one of the most ambitious health system transformation agendas in the world. The country is shifting its health system towards prevention, towards equitable access, and towards integrated data-driven service delivery. These reforms are spanning primary care, hospitals, financing, human resources, and health security. And together, they're helping to reshape how health services reach all the communities across this vast archipelago. They demonstrate that strong leadership, clear priorities, and sustained commitment can drive meaningful change at scale. Indonesia's example is also influencing the region and the world through the HealthWorks Leaders Coalition and the recent Universal Health Coverage High-Level Forum in Tokyo. The World Bank Group is proud to support Indonesia in this transformation. Our partnership is focusing on priorities that matter most to Indonesia's people. This includes the health insurance JKN, quality nationwide health services, reductions in tuberculosis, reductions in stunting, and reductions in cervical cancer. In addition to financing, our joint work is including impact evaluations of stunting prevention, technical assistance on provider payment reform, and analysis that can strengthen Indonesia's health workforce and understand the sector's broader economic impact. Early findings in this work on the economic impact of the health sector indicate that every additional 1 rupiah of demand in the health sector generates between 2 and 3.2 rupiah in output across the economy. So that's quite an interesting multiplier effect. By 2030, the health sector is expected to directly account for 2 million jobs, indirectly support another 4 million jobs. It's an important point. Investing in health is not just a social priority. Of course, it is a social priority, but not just a social priority. It's also a driver of growth, a driver of productivity, and a driver of jobs. The report that we're launching today speaks to challenges Indonesia and the people of East Asia and the Pacific face. And that is that people are living longer, but not always healthier lives. Chronic diseases like diabetes, hypertension are on the rise, especially among working age adults. The human and economic costs are already substantial, and they will continue to grow. The most effective response lies in strong primary healthcare systems that focus on prevention, early diagnosis, and continuous care management. And Indonesia's reforms, including investments in primary care networks, in digital health, in workforce strengthening, and improved financing, they are fully aligned with the recommendations of this report. The World Bank Group is committed to supporting these efforts, including outreach to underserved communities across Indonesia's thousands of islands. Let me close by expressing appreciation to all of the authors and contributors who have made this possible, and of course a special thank you to Minister Budi for hosting this event and for the steadfast commitment to building a healthier individual. Thank you very much. Terima kasih banyak.
Thank you, Ibu Carrie. Ladies and gentlemen, we will now hear welcome remarks from Mr. Carlos Felipe Jaramillo, Vice President, East Asia and Pacific Region, the World Bank, who's joining us virtually. Please welcome Mr. Jaramillo.
Hello, good morning, good evening, wherever you are. Honorable Minister, distinguished panelists and participants joining us from Jakarta and online. It is my pleasure to join you for the launch of this important World Bank regional report. I truly regret that I couldn't be there in Jakarta in the event in person, but I'm here in the region today in Kuala Lumpur. But I am sincerely grateful to you, Honorable Minister Budi, for hosting this event in Jakarta. Health is often taken for granted. We rarely notice it when it is present, and yet when we are not healthy, we know it immediately, and we worry. I worry. Many countries in this region, in East Asia and Pacific, have achieved remarkable economic growth, and investments in health and education have been a critical driver. But there are still challenges and there's progress to make. We know that individual health outcomes, taken together, shape the overall health of populations, and indeed of economies. When people are healthy, they're more productive, and they're able to work longer, more effectively. This improves household incomes and drives national economic growth. By contrast, poor health reduces productivity and shortens working lives and imposes high costs on both households and governments. We at the World Bank Group are firmly committed to improving health outcomes in East Asia Pacific and actually around the world. We have a global goal to support countries in delivering better and more affordable healthcare to 1.5 billion people by 2030. That drives a lot of our activities around the world. And we believe that achieving this goal could generate up to 29 million jobs, which would also advance economic development. The report we are discussing today, called A Healthy Future, highlights a critical challenge. While people are living longer and economies continue to grow, the rising prevalence of diabetes, hypertension, and heart disease threatens to undermine these gains. These conditions affect individuals in their most productive years, and they place an increasing strain on families, health systems, and economies. This epidemic of these diseases, the so-called non-communicable diseases, is very likely to intensify, driven in part by rapid population aging and lifestyle changes, unless we act decisively to prevent these conditions before they arise. Within the health system, the most effective means of prevention, we believe, and I think it's been demonstrated, is primary healthcare. The promise of primary healthcare is its ability to deliver services that are effective, efficient, and equitable. Investments in primary healthcare yield some of the highest economic returns in the health sector. Yet, despite its proven value, primary healthcare is a tool that remains underutilized in our region, resulting in missed opportunities across many countries in East Asia and the Pacific. In a region whose growth has long been fueled by investments in people, we believe strengthening primary healthcare to protect and expand human capital is a huge priority. Investment and incentives are essential to enable primary healthcare to do more and to do it better by expanding access and by delivering high-quality services. At the same time, individuals must be supported to adopt healthier behaviors through better information and to good incentives. Only through this combined effort can the full potential of primary healthcare be used to fend off the growing burden of chronic disease. So this report that we're discussing today, A Healthy Future, is very timely. Across East Asia and the Pacific, the role of primary healthcare is evolving as countries develop, as disease patterns shift, and as populations age. In response to these changes, this report sets out innovative, country-tailored reforms that reflect diverse health challenges and level of development. Drawing on global evidence of successful innovations, as well as the experience of many regional practitioners and policymakers, it makes a compelling case for why primary healthcare must be prioritized for the benefit of individuals, for the benefit of the economies, and for the benefit of the societies as a whole. Will there be challenges? Yes, there will be challenges. Political economy constraints, entrenched interests, and limited resources will need to be addressed with pragmatism and creativity. Strong partnerships and collaboration at the highest levels of government, within communities, between care providers and the people that they serve will be crucial to achieve sustainable reform. The private sector and development partners will also have a critical role to play. So today's panel brings together perspectives from ministries of health and finance, from development partners and the private sector. I very much look forward to hearing from our distinguished panelists on how we can work together to seize this opportunity and to boost the region's remarkable progress. Thank you all for joining us, and Tarima Casa.
Thank you very much, Mr. Jaramillo. May I also share that Mr. Jaramillo will remain with us to continue to participate in the program until the conclusion of today's event. Ladies and gentlemen, it is my honor to invite His Excellency Budi Gunadi Sadikin, Minister of Health, the Republic of Indonesia, to deliver his keynote speech.
Ladies and gentlemen, hypertension is one of the what we call a silent pandemic. And with the rain that happenings in Jakarta, not only in Sumatra, traffic became very, very bad. And my apology, I believe also I increased my hypertension in this morning because I came late, by 15 minutes. So, ladies and gentlemen, Carrie has shared how investment in health can produce GDP growth and jobs. So 1 rupiah can be translated into 2 up until 3.2 rupiah growth. And in the next 5 years, we will provide 2 million jobs, new jobs, directly related with healthcare, and about 4 million indirectly related with healthcare. Now I want to see from the other side of the balance sheet, not only the output side, but the input side. What I'm afraid, and it is very suitable because Pak Gufron is here, Pak Gufron has a lot of pressure on his P&L account on the healthcare expenditure year by year. And the reason why the pressure is there, because in the facilities that we have become better. When the facilities become better, then more Indonesians come to access to the facility that they never had a chance before, and these healthcare facilities start issuing a claim to BPJS, and that put a very strong pressure to BPJS cash flows. And that start happening. What I would like to share with you, and this is some ambassador are sitting here, my biggest worry is the cost of healthcare in every country always increase higher than GDP increase in those particular country. It is like we have a company that the expenditure increase is always higher than an income increase, which is totally unsustainable. So therefore, it is very important for every health minister to get help from World Bank who understand finance. The health minister usually they don't understand financing. To help reduce this cost growth in health cost inflations, so the country can still keep financing the healthcare services of their populations, without a lot of pressures in the country financing. So I give an example that I always use. US is 79 years average life. Panama and Cuba is 79 years average life. Average US spend 11,900, and average Panama and Cuba spend 1,900. 10,000 US different. So there is no justification if you reach 70 years old and you're still holding or you're still living in US. You should migrate to Panama and Cuba. And you can save 10,000 US every year and can use it to have a holiday in Bali, rather than to spend that money to the hospitals, to the doctors, or to the pharmaceutical companies. And that is a very stark difference. Japan, 84 years average life, more than the US, they spend 5,000 each, half of the US. South Korean 84, they spend 4,000 each. Singaporean 84, they spend 3,300. How come the difference is so big? Because this is one of the industry where the information asymmetry is extremely large. You can do ChatGPT and check. If you want to do appendectomy in the US, how much does it cost? If I'm not mistaken, it's around 12,000 for that procedures. If you do it in Japan, it's around 5,000 US. Do you think Japan doctors are worse than US doctors in doing appendectomy? So the US doctors justify double the price of the Japanese doctors. You go to Indonesia, you can get it appendectomy less than 500 US. I don't know whether you still want to do it, but I will, for appendectomy, I will do it in Indonesia. I will do it in Indonesia. And I can save, 11,500 US dollar compared with I do it in US. In banking sector, in financial sector, that will never happen. You want to trade FX, you want to trade bond, you want to trade equities, all money market, all financial products. This price gap will never happen. All the bankers will start doing arbitrage and make a lot of money by doing it. It's only happened in healthcare sector because the information is very asymmetric. Now the problem is that it creates hidden costs. This transparency in the global healthcare systems create a massive burden financially. So that's why we have to make sure that we can control it. My worry is in Indonesians. If Indonesia average life now is 72, we spend 140, we increase to 76, Malaysia that spend 300 US more, 430, 300 US difference in the next 5 to 10 years, then 300 US multiplied by 280 million is 84 billion US dollar. The country need to spend 84 billion US dollar every year because we need to carry the aging population from 70 to 76. If we go to Singapore, one of the most efficient, 3,300, 3,000 US different, multiplied by 280 million, 840 billion US dollar, half of our GDP, need to be spent just to make a sustainable healthcare services to our aging populations. Now, it is my dream and my job that we have to make sure we go the Singaporean trajectory, not the US trajectory in terms of health cost per capita. And when I start learning why is Singapore different in the US, why Japan better in the US, why some other country, the health cost per capita versus the life expectancy is totally different with other country. There is very obvious single observations. The country that have a very long life expectancy and very low health cost per capita, they have a lot of focus in primary care. They keep the people healthy, not cure the sick people. As simple as that. If any Minister of Health strategy is to cure sick people, definitely it will be much more expensive if the strategy is to keep people healthy. That is maybe the reason why the name of the minister is always Minister of Health, not Ministry of Doctors or Minister of Sickness or Minister of Cure. Always Minister of Health. That is very, very important. So that's why Indonesia do a massive 280 million mandatory free screening programs. So we identify the hypertension and blood sugar and cholesterol level before they become stroke or heart attack. Some countries' strategy, we establish a very sophisticated and strong hospital system to handle stroke and heart attack. Some other countries are smarter. Their strategy is to keep the hospital empty, but keep the population healthy, so they control the blood sugar and blood tension, so they don't have to go to the hospitals. Ladies and gentlemen, I will share with you my last observations. Indonesia now is 74, to my surprise. We just increased to 74 from 72. When I joined, it's 72 average life. Now it's 74. So that's why we can feel the pressure, the cash flow pressure to BPJS very, very strongly because we increased it to 2 years the average life. When I had a meeting with Japanese officers or Singaporean delegation of Ministry of Health, I can see 3 major differences between my team and their team. The first difference is the size of their tummy. The Singaporean team usually is like me, or better. The Indonesian team is like Ronald. That is my observation. You know the second observation that I noticed? When I see the color of the drinks, the Indonesian delegate drink coffee, teh bottle, red one, maybe some orange juice, orange, and some grapefruit juice, green. The Singaporean, they only drink water. So the color of the drinks are the second difference. You know the third difference? Usually they have options to order the food. The Indonesian will order steak, will order nasi goreng, will order satay. The Singaporean only order fish. So ladies and gentlemen, that shows why the Singaporean can live up to 84. So they are healthier. I don't know whether they are happier or not because we are still smoking and eating fish, but definitely they are healthier. So for all of you, I wish you all can live healthy, live long, and live rich. Thank you.
Terima kasih Bapak. Bapak mohon untuk tetap berada di atas panggung. Terima kasih. Dan untuk bergabung bersama Bapak Menteri, we would like to invite Mr. Aditya Matu, Chief Economist East Asia and Pacific Region, the World Bank, to formally give the report to Bapak Budi Gunadi Sadikin. We're arriving at the heart of today's event, a ceremonial report handover of the World Bank's publication, A Healthy Future, Primary Healthcare and the Chronic Disease Epidemic in East Asia and the Pacific. This handover symbolizes the passing of knowledge, trust, and responsibility from its creators to those who will preserve and share its value. We would also like to invite Ibu Kerry to join to have a photo session. Mari kita abadikan. Okay, terima kasih. Thank you very much. You may return to your seats. Ladies and gentlemen, now let's hear the presentation of the key findings of the report. The presentation will be delivered by the authors of the publication, Mr. Akash Mohpal, Senior Economist, Health, Nutrition, and Population, the World Bank, and also Mr. Zelalem Yilma DBB, Senior Economist, Health, Nutrition, and Population, the World Bank. Gentlemen, the floor is yours.
Hello? Yeah. So we are here to present the key findings of the report, a healthy and hopefully a happy future. Just to walk you through the structure of the presentation, we're going to talk about the state of health in EAP, the promise and the reality of primary healthcare in the region, and finally, some ideas as to what can be done to transform primary healthcare. So let me start with the state of health. We heard from Budi and Felipe about the NCD, or the chronic disease epidemic, coming to the region. So let me start with this graphic first. In this picture, what you have on the x-axis is the under 5 mortality rate, right? An indicator for child health and an indicator for broader maternal and child health. On the y-axis, you have the probability of dying from just 4 NCDs, non-communicable diseases. And those diseases are cardiovascular diseases, cancers, diabetes, and chronic respiratory diseases. This is the situation of EAP in the year 2000. You see all the countries, most East Asia countries, clustering here in the top right quadrant. They have high under 5 mortality rate and high rates of NCDs. Right? The probability of dying from the probability of adults dying from NCDs is quite high in some countries that you see up here. Fast forward to 2023, there has been quite a bit of progress. This whole distribution has shifted in this direction. That means you have improvements in under 5 mortality, which is very good news, but not so much improvement in adult NCDs or chronic diseases. So you really have this chronic disease epidemic coming to the region. The region has made progress on child health, but not on NCDs. Contrast that to the Pacific Islands. The same picture, the same axis, the year 2000, the year 2023. 2000, 2023. NCDs have stayed stubbornly high, whereas maternal child health, as proxied by under 5 mortality, also has not moved too much. So in contrast to East Asia, where we see the NCD epidemic, in the Pacific, we see persistently high NCDs, and in addition, an unfinished maternal and child healthcare agenda. Moving on, and this is something Felipe was referring to, NCDs are both a health and economic problem, and they are increasingly becoming a larger economic problem. This is the number of healthy years lost to non-communicable diseases, the same 4 non-communicable diseases, either because of the person spending time in sickness or death, right? So of every 100 years of a healthy life, how many years are lost? The blue line here is 2000 and the orange line 2021. What you see is a marked increase in the incidence of LCDs in the non-communicable diseases from 2000 to 2021. And in particular, you see these NCDs or chronic diseases affecting people earlier in their years and in their productive years. In fact, in the 55 to 59 year age group, the burden of NCDs increased by 50%. This means not only higher healthcare costs, but also economic costs due to lost productivity, absenteeism in the workplace, and costs to individuals, families, and communities. Okay, moving on. The NCD epidemic is going to get much worse because of the headwinds facing the health sector. EAP is aging, and EAP is actually aging faster than any other region in the world, and that's the blue line. By the year 2041, 1 in 5 people in the region will be 65 years or older. Again, aging is a risk factor in itself for NCDs, so this is something that's going to exacerbate the NCD epidemic. You have rapid urbanization occurring in EAP in the regions. With urbanization, what you get is changes in lifestyle, access to unhealthier foods, your drinks changing colors, and you see the impact of that on the right. In all East Asia and Pacific countries, the share of population that is overweight has increased in the last 2 decades, right? So much so that in more than half the countries, 1 in 2 adult is overweight. Finally, changes in extreme weathers also exacerbate the effect of NCDs. And here is one piece of evidence for that. During times of heat waves in Indonesia, you see an 8% increase in healthcare facility visits, which should be a concern for BPJS. When we look deeper, the number of visits or the increase in visits due to chronic conditions like diabetes and cardiovascular diseases is even higher, right? So in the face of climate change, the burden of non-communicable diseases is going to increase further. So now we'll go into a little bit into the promise and the reality of primary healthcare and try to examine how primary healthcare has functioned in the region. So in thinking about how to evaluate primary healthcare for this report, we came up, or we thought about what patients value or what patients want from primary healthcare. The first thing they want is it's accessible. They can conveniently go to a health facility. It should be affordable. They don't have to pay too much. It should be comprehensive. It should provide care for all the things that the patients or the households need care for. The care should be of high quality. Care should be continuous. If the patient needs care at the primary care level or hospital, there should be continuous care. Care should be continuous over time. And finally, the patients should feel that they are in charge of their own health, right? So if you agree with this, I'll ask my colleague Zelalem to tell us if this promise has been lived up to in EAP.
Thank you very much, Akash. I will now walk you through whether or not the promise of primary health care is fulfilled in EAP. As Akash mentioned, we did go through in the report on each of these dimensions of strong primary health care. And the results are a bit sobering. Am I getting this right? Okay. All right. So Akash mentioned that the first dimension that we looked at is accessibility, right? How far people have to travel to the nearest primary health care facility. Overall, the trend shows a positive sign. Urban areas have better access, but rural and remote locations still have a way to go. And this is a geospatial analysis that we conducted here in Indonesia. And as you can see, in provinces like Papua, about 45% of the population has to travel for almost 2 hours to reach the nearest primary health care facility. And of course, the implication of this access issue is the fact that there is not enough progress in terms of coverage of services. And we did look at this. I'm sure some of you are aware of the Universal Health Coverage Index. For almost all countries in EAP, the service coverage index is much lower than expected for each country's income. Of course, the most straightforward explanation that we often hear is that we have less resources for the health sector, which is true, right? Except the Pacific countries and Timor-Leste, as you can see on this graph, healthcare spending, public care spending as a share of GDP is quite low. But it's not just a question of low, inadequate resources. There is also significant misallocation of resources. Across health systems, as Pabudi noted, we tend to emphasize treatment over prevention. And the implication of this is that there is inadequate provision of primary health care and over-provision of unnecessary, sometimes necessary, but avoidable treatment. This is a study that was conducted in Vietnam. And what you see on this figure is that about a quarter of total inpatient health costs in the entire Vietnamese health system could have been avoided if we had a strong primary health care that would have prevented or managed the NCDs from becoming complicated. A quarter to 1/3. That's a significant amount of the cost, and I think part of the explanation that explains why some countries have a very poor outcomes. Second, not enough workers. Nobody will be surprised with this. We've been saying this for a long time. And of course, also unevenly distributed. We're quoting here Indonesia again because Indonesia does make data available and we're very grateful for it. As you can see, in Indonesia, in the eastern parts, for example, the percentage of fully staffed public primary health care is as little as 2%. But if you go to Kalimantan, Selatan, it is over 87%, and in Jakarta, almost all facilities. So unevenly distributed, shortage of workers, but not only that, we also have an issue with capacity. The competence of healthcare providers to provide necessary non-communicable disease services is limited. A nationwide survey that was conducted just a year ago showed that the average score for physicians for common NCD and other primary healthcare services was only 67%. Yeah? Even when there is knowledge, and this is another evidence that comes from China, where we assessed the knowledge or competence of a physician to do correct management of conditions, and we get about 81%, which is not so bad, right? But these physicians do not practice what they know. There is less effort. You see only 36% correct management in practice. So not enough resources, unevenly distributed, not enough knowledge, and we don't execute what we know. And some of this have to do with incentives that we'll come back to later on. Another important point, and I think Pabudi mentioned this earlier on, is the issue of motivation for preventive behavior. We have high rates of smoking rate, as you know, in our region, and the rate of decline in the smoking rate is not as great as the rest of the world. There is increased consumption of alcohol, and the rate of increase in EAP is actually much higher than the rest of the world. There are a lot of people with high blood pressure that are still not aware that they have blood pressure. And in EAP, this ranges from 45 to 55%. People who have high blood pressure but not aware of it. So these are really speaking to preventive behaviors that we are not seeing. So what's the implication of all of this? And we thank a famous paper that most of you might be aware of by Margaret Crook and colleagues, shows excess days due to lack of prevention. Across all these countries that you see, we have significant number of people dying because of lack of prevention. And some, of course, because they are not accessing care, the point that we mentioned earlier, but most importantly, due to poor quality of care. A very sobering result in this paper is the fact that in EAP, over a third of total avoidable excess diseases are attributable to poor quality, even more so than access-related issues. Now the question is, what do we do? How do we tackle this issue, right? So in this paper, what we are stressing are two things. One is the increased use of technology to tackle some of the issues that we have highlighted, and to continue the impetus of reform in the health sectors that we saw after the COVID-19 pandemic. We identified 4 reform directions. The first one is enhancing supply and tailoring the supply to specific NCD service needs. Second, monitoring quality, and I will come to these points later on. Incentivizing performance, and most importantly, stimulating demand so that people can have preventive behaviors and address issues before they become complicated. Of course, some of these, as I said earlier, requires quite significant infrastructural investment. It requires investment in our number of healthcare workers, doctors, etc. Right? But this is going to take time, and it's going to take a lot more resource. So in the interim, we have several things that can be done. Things that have been tried and have been shown to be effective. And the use of technology to widen access, for example, could be seen from telemedicine. Across 25 countries where we had this survey, about 18 of them practice telemedicine in some of their primary healthcare facilities. So this is something that needs to be scaled up so we can reach people who are in remote areas, and also to allow people to access specialist services through teleconsultations, etc. The second point, which is also really related to the underfunding issue that we spoke about earlier, is the fact that most of our primary healthcare facilities, they don't have specialized services, right? Like there is no radiologist in most primary healthcare facilities in EAP. And one way to address that challenge is to connect primary healthcare facilities to specialist services at higher levels. A prime example that we cite in this report comes from China, Fujian City, where all primary healthcare facilities were linked through a cloud solution to radiologists that are sitting elsewhere. So you send your imaging and you get report on what the diagnosis for that patient would be. And this is something that could be used given the technological advance that we have. Second, we need to bring services where people can access them and where people choose to access them. And a prime example, again, on this is the use of mobile medical clinics. And Mongolia is another country that has done this successfully and increased preventive health service coverage. And the second one, which is a point that we also strongly make in the report, is to make use of hospitals. A lot of people in urban areas tend to underutilize PHCs and go directly to hospitals. So what we need to do is make sure that they don't directly access specialist care, but we have to put in place a department of primary health care within hospitals so that we can make sure those people are receiving those important primary health care services, with, of course, triaging function to help them access specialist services. Third point is about HRH issue, health workforce issue. And again, task shifting, task sharing, these are other innovations that have been experimented and have been shown to deliver results. In Nigeria, in China, this is a result from China. For example, in the management of cardiovascular risk factors, non-physician health workers have been found to deliver as much, even better results than physicians. So the result is there. We just have to build upon it and scale up and address the HRH shortage that we have in the interim. The second reform area, so the first one was really making sure that our supply is tailored to the needs of non-communicable diseases. The second one is about monitoring quality. So in our assessment, most countries do assessment of quality, but it's really about structural inputs, whether we have doctors, whether we have drugs in place, etc. But no assessment of process quality or clinical outcomes as such. So we need to move towards monitoring patient experience, patient outcomes, right? And most importantly, engage the community in the monitoring of health and clinical outcomes. This is the result from Uganda, for example, where community-based monitoring evaluation was done. And as you can see in this graph, there has been significant rightward shift in the nutritional outcome that was measured. And they find the same result for health outcomes as well. One important point that we need to highlight is the importance of making these performance measures public, right? We don't just evaluate it, but we also make it public so that people can vote with their feet. Right? The third result reform area is incentivizing performance. We need to start thinking about how do we incentivize proactive screening and management of NCDs at primary health care. Yeah? Incentives have proven to be effective, and particularly when you have a capitation-based payment system where you link a population to a specific facility, pay the facility per member, and make sure that you pay them for results of the population that they serve, the health of the population that they serve. So performance-based capitation, and again, Philippines, Indonesia, Mongolia, these are countries that have experimented with capitation with performance component as well. Performance-based financing in general has also been shown to be effective, particularly in increasing uptake of preventive services, mostly on the institutional delivery, preventive maternal and child health services, etc. But the results are very staggering, from 23% to 132%. Not only the use of services, but also quality. As I said earlier, doctors do not often practice what they know. Yeah? The effort that they put in is suboptimal. And an evaluation of a performance-based incentive has also shown that we can reduce the gap between what people know and what they practice through performance-based incentives. The last reform area is stimulating demand. And how do we do that? 3 points here. One, we need to really make use of our technological advances to inform the public about health behavior, to inform them about the need for regular health checkups, to inform the public about adherence to treatment of NCDs. Before the diabetes and the hypertension that we diagnose ends up being a stroke and cost the health system, right? And this is another evidence about SMS reminders on taking your medication. And as you can see, a significant difference between the control group and the treatment group, showing the effectiveness of just sending a reminder on SMS about taking medications on time. So you inform and you nudge. And behavioral nudges, in our region, Japan is a country that is known for this. Nudges, for example, like not asking people whether or not they want to take cancer screening, but making cancer screening a default option that people can opt out to if they choose to, right? So these kind of behavioral nudges have shown to increase screening uptake for cancer from 36 to 53% in Japan. In Indonesia, we have now the birthday screening program, as you all know. Again, a free birthday screening program that you are entitled to get if you seek the checkup within 1 month of your birthday, and something that you lose afterwards, right? So it's a behavioral nudge again. So we have to start thinking through these kind of innovations to stimulate demand. Last but not least, information and nudging sometimes might not be enough. And when that's not the case, we have to incentivize. And I'm sure all of you are familiar with some of these experimentations on conditional cash transfers to incentivize these kind of behaviors. Here is a paper from Armenia, where financial incentives for screening for diabetes and hypertension showed a significant increase. The comparison group has like 4% screening, and if you just send invitations, personalized invitations, Pagufron, please take your medical checkup next month, increases your screening uptake by 19%. And if you accompany that with some incentives, conditional cash transfer or voucher, the increase is all the way up by 31%. So very effective. So these are the reform areas. And I know we have a lot to do. We've shown there is a lot that can be done, and all of them cannot be done at the same time. Right? We need to look at the reforms and tailor them to our specific country needs. As Akash showed earlier, there is some variation in the region in terms of performance on adult NCDs versus maternal and child health outcomes versus elderly care needs. Right? Countries like China and Thailand, where aging is a big issue, might have a different assignment than countries like Kiribati, for example, and PNG, where there is still reproductive and maternal child health care needs. Second, there is quite a lot of variation across countries in terms of digital readiness, the ICT infrastructure that we have, which determines what aspect of the digital health solutions that we highlight here can be adopted. Right? Second consideration. Third, fiscal space. Yeah? We have countries, upper middle income countries, low income countries, countries with different levels of revenue mobilization capacity, and depending on that fiscal space, we'll have to adjust the set of reforms that we have. Last but not least, and we are speaking here in a country where political economy related reforms have happened over the last few years, and we look forward to some of the discussion later on. These are important considerations because some of these reforms would affect some vested interests. And with that, I will end the presentation and hand it over to the next, to the MC. Thanks.
Thank you, Akash and Zelalem, for the presentation. Ladies and gentlemen, we now proceed to our panel discussion. Our panel discussion will further explore the implications of the report's findings. Our esteemed panelists, representing Ministries of Health and Finance, the donor community, and the private sector, will cover practical pathways forward as the region works to combat NCDs through strong primary health care. The discussion will examine how countries can prioritize spending for prevention, leverage the private sectors, use technology to expand access to services, and to improve quality of care. To guide this conversation, please welcome our moderator, Mr. Aditya Mathu, Chief Economist, East Asia and Pacific Region, the World Bank. Ms.
Do you expect me to say something now? I thought I was going to be joined by other panelists on stage. Yes. Are we connected to the other panelists? Babati, you should. Thank you very much for joining us. Now, we have a panel. I apologize to our online panelists. You've had to wait longer than we had hoped. I was going to wonder, are you going to introduce the panelists or would you like me to do it? Okay. So we are very fortunate to have with us Mantri, Minister Budi, who is our host here today. We also have present on stage Dr. Beverly Ho, who is representing the private sector, the academic sector, and also has a past in the government. Online, we have very luckily Vice Minister Ms. Kulan Bat Erden of Mongolia, of the Vice Minister for Finance. We have also Ms. Rosemary McKay of DFAT in Australia. And we are also very fortunate today to have, I'm trying to, the Permanent Secretary Shri Gonda of Fiji. So we have, in a way, 2 people from Ministries of Finance and 3 people who are invested and in the healthcare sector. And so what I propose to do is dig a little deeper and draw upon their immense expertise to illuminate further some of the questions we have addressed so far. So Minister Budi, to begin with, we've seen that reforming primary healthcare poses political, fiscal, technical challenges. Now, if I can ask you, in your current role, you sketched brilliantly the challenge. But what is the single biggest difficulty you faced in nudging the primary care system towards addressing non-communicable disease prevention and management? And what are you doing to overcome that challenge?
So as I shared before, non-communicable disease is a chronic disease. It's not an acute disease. So when you got hit, it will take another 3 to 5 years before you really get stroke or heart attack. So we have time, to improve our conditions. And as I mentioned to you, the best way to do it, the cheapest way to do it, is to do preventions. What does it mean by prevention? It is promotive, and prevention means that you have to change the lifestyle of each of the individual lifestyle. And number 2, you have to prevent. Basically, it is immunization and screening. Those 2 things. When you get screened, it is your hypertension is bad and you take the pills. Now, which one are the most difficult one, and in my view will be the most successful action plan? It is on the promotion side. Like I mentioned to you about the Singaporean and the Japanese. If we can successfully educate 280 million of Indonesians to live healthy, and we can transfer the ownership to them, then 50% of our job is done. And it would be very, very cheap. Because then they don't need to take the pills, they don't need to go to screening. I mean, they still have to go to screening every year, but then the lifestyle changes will be done by them. This is not a program, this is a movement. If we can create a healthy movement across 200 million, 80 million of Indonesians, that is the best things that we can do. We should do.
But I still would like to hear, politically, fiscally, technically, what is the binding constraint on your ability to move forward?
This is a typical banker's questions. Because I still remember when I joined as a Minister of Health, and all Ministers of Health said, we have a fiscal problem, we don't have money, we don't have any fiscal capacity. I'm scratching my head, I don't have that problem. Why? Not because I know Ajay Banga personally, because when the budget is being limited, and the grant money is, I look for grant. So I increase my grant from 300 million to 1 billion. So it doesn't depend on Ministry of Finance. And the grant money is not going down, I look for loan. I got 4 billion from World Bank, thank you. World Bank and the other bank. So for me, it's about money. Money is there. It depends how smart you are in getting the money. So if you ask me about money, actually Indonesia now, money is not the main issues. And I can share with many other countries, that you can find money. Money in health is the easiest way to find. I'm a banker. If you want to produce petrochemical industry, building electricity, the money is more difficult to get rather than healthcare sector. Healthcare sector, everybody want to give you money. Bill Gates want to give money. The Wellcome Trust want to give money. The UAE ambassador there gave me 300 million of US dollars to build a hospital. Free money. You know, and I don't need a government budget from Ibu Sri Mulyani at that time. So it is not. Believe me, if you are gearing me toward money as an ex-banker for 30 years, money is not an issue in healthcare sector. You just have to find a way, a smart way to look for money. And I want to train all of the healthcare ministers. You cannot ask money forever. There should be a very clear financial pathways from receiving the money from grant money and be independent. You cannot behave like a child where every year you reach 40 years old and you still depend on your mother and father to ask for money. So that is the attitude that I'd like to share with many other health ministers across the world, that money is not there. You can find it. You just have to work hard. If you don't understand, I can help you.
So let me get another perspective. We're turning to a source of money. So Secretary Shiri, in Fiji, we know that non-communicable diseases are imposing an immense cost, as much as 5% of GDP every year. So I'd like to hear, how do you evaluate health sector investments compared to other fiscal priorities? And also, if I can ask you, what are the key reforms and investments that Fiji is undertaking to deal with this immense problem that you face?
Thank you very much, Aditya. I'm just coming out of a panel where we discussed about Fiji's tourism, and there's this catchy line here which we market our tourism saying that Fiji where happiness finds you. While we have a lot of happy people here, but we are a very unhealthy country. As you have seen from all the slides, I think Pacific Island countries and specifically Fiji, we have a major NCD crisis in Fiji with a lot of diabetes, cardiovascular and hypertension issues. And this is coming at an extremely high fiscal cost. And if we continue on the current momentum in terms of the challenges in the health sector and not fixing this issue around NCDs, the fiscal cost is unsustainable. And even more worrisome than the fiscal cost is the economic cost that we are incurring. I mean, as you said earlier, there's a huge working class population that is suffering from NCDs. And Fiji has one of the highest rates of diabetes, including amputations related to diabetes. That's causing significant issues in terms of people not being able to walk. So we already have a small country with skills issues because of migration. And on top of this, this NCDs crisis is affecting our workforce. And apart from that, I mean, not having enough people to work, we are having issues around productivity and absenteeism. So there's a big fiscal and economic rationale about why we need to focus on primary healthcare from a fiscal perspective. However, I think just getting to your point around the political economy, I mean, as a bureaucrat within government, from a health perspective, it's an economic and fiscal perspective, it's easier to agree on this need to refocus attention resources on primary healthcare. However, I think the political economy side of things can be complicated, especially given that we already have a crisis. There's huge public expectations and political pressure in terms of providing support to tertiary care and addressing and curing the problem. So politically, the politicians and government is under immense pressure always to address on the tail end of this problem, whereas the attention is needed on the preventative primary healthcare side of things. And similarly, there's also, I think the Honorable Minister was trying to say that, maybe I can say it from our side, there's also certain interest groups that maybe necessarily would not like to move towards primary healthcare because there's potentially private sector can make money on the tertiary care side. However, I think we all need to address this, and I would like to thank the World Bank for all the support that's currently being provided in Fiji. We have embarked on a major transformative health sector project with the support of the World Bank and the Asian Development Bank, and of course the government of Australia. And I think it's through this kind of technical reports that's coming out. We had a major technical study in Fiji for the health sector review, which which needs to create better awareness amongst policymakers, our citizens, to create this momentum. And I think the Honorable Minister for Indonesia said this needs to be a movement, and it needs to start from individual levels up to the policy making level. So this kind of support, this panel discussions, report, awareness is very critical. And I said earlier, I think as a finance person, I only figured this out in the last 3 years that we need to focus more on primary healthcare. So definitely that awareness is needed. Thank you.
Thank you, Secretary. You know, I think it's very wise to not look at budget constraints, but look at the high rate of return on investments in healthcare and how they also help eventually to relax the fiscal constraint, the growth constraint. But you mentioned the Australian government, and Rosemary, we are lucky to have you here. You know, donor countries often feel more concerned about pandemic diseases which have global externalities. What challenges do you face in creating greater support for strengthening primary care to address non-communicable diseases in smaller and poorer countries?
Yes, thank you for the question. There's a little bit of an echo. Okay, it seems to be fixed. It's true, and as development partners, we acknowledge that the complex long-term nature of NCDs requiring a multi-sectoral approach and often more difficult to demonstrate results against can be harder to build an investment case for compared to communicable diseases. However, there really is increasing global recognition, and I think that's true within Australia as well, that NCDs and communicable diseases are intertwined, impact on health security as a whole, and that by building stronger primary healthcare systems, we support reducing infectious diseases, supporting maternal and child health, and tackling the NCD burden. So we all need, particularly development partners, I think, to think about reframing actions in NCDs as an investment, as a foundation to resilient and equitable health systems instead of as a cost. Collective advocacy for NCDs is critical, and so is the evidence that we need to support this. And Australia is really pleased to have contributed to this flagship report through our partnership with the World Bank, and congratulations to everyone who worked on it, because it so clearly illustrates that investment case, the huge impact of NCDs in the region, particularly in the Pacific, and offers practical suggestions on how to address them. And it also makes a very strong economic case for investing in NCDs. But I just wanted to say that in addition to getting more financing and more money to investing in NCDs, ways of working are also really critical to be effective. And this includes taking an integrated systems approach rather than vertical or one-off funding. And I really commend the World Bank and the Asian Development Bank by its mutual reliance framework, looking at how it can work in a more coordinated way with countries like Australia behind it, and really pleased that one of the first examples of its use is in the Pacific to address NCDs through the FIT program. But development assistance can also play an enabling role in supporting the piloting of new approaches. And Minister Budi, we are really pleased that Australia has been able to partner with Indonesia through the Prosperous program to develop and pilot the new model for Indonesia's integrated primary healthcare system, which is now being rolled out nationwide. And we really look forward to continuing to work with you on innovative approaches. But finally, and most importantly, we need to back government leadership and locally led approaches. And this brings me to highlight the important role that our 10-year commitment to date to the World Bank's Advanced UHC Multi-Donor Trust Fund has made as a way in which Australia, the World Bank and other development partners have supported governments to develop and implement their own reform priorities through building knowledge and evidence, technical assistance, catalytical financing and country-to-country learning. And I wish to congratulate Fiji in particular for making use of this technical assistance through embarking on a very ambitious health sector reform. So in summary, To shift more resources and emphasis to NCDs, we need to build stronger collaboration between governments and development partners, coordinate our efforts, use evidence-based approaches, and continue to collectively advocate for NCD action as a priority. Thank you.
Thank you, Rosemary. If I can now turn to you, Vice Minister Kulan. You know, Mongolia stands out as one of the countries in the region which spends a relatively large share of its budget on healthcare. But we heard also from Permanent Secretary Shiri that there is often pressure, political pressure that favors spending on hospitals and tertiary care. How can you ensure, and what are you doing to ensure, that there is more spending, as we heard, towards prevention and early detection?
Good morning, everyone. Thank you for all of your attendance and sharing the very insightful report that has been just published. So back to your question, it is very, how can I say that it's always a very tricky balancing act between political economy and also spending toward early prevention and early detection. So from a fiscal sustainability perspective, our late-stage hospital treatment is significantly more expensive than early detection and prevention, especially given Mongolia's growing burden on non-communicable diseases. So since 2021, Ministry of Finance has pulled the state health budget into the health insurance fund and introduced centralized strategic purchasing in order to improve efficiency and accountability. And also last year, the 52% of health insurance fund resources were financed by the state budget, while primary healthcare services were fully state funded and provided free at the point of use, which strengthened the equity and access to primary healthcare. So in the past years, specifically back in 2020 and 2022, the ministry doubled the primary care captivation payments and approved an additional 40% increase starting in 2026 in order to strengthen the fiscal viability of frontline care. But what I would like to highlight as well is that there is still an efficiency gap remained because hospitals treated 1.9 million patients in 2025 and received 323 million USD, while primary care facilities treated 1.8 million patients but received only 10 million USD. So the thing is, the finance and budget and investment is important, but it's only like one part of the bigger puzzle. So I want to agree with Rosemary as well in saying that we need a whole of a government approach and inter-sectoral coordination in this effort. Although budget and finance plays an important role, we still need efficiency within approved budget. We still need accountability of the money invested into primary healthcare. And there is also like a lot of, I would like to highlight the importance of public awareness in primary healthcare services, and also behavioral nudge, which was rightfully highlighted in the report. Because from a common citizen perspective, especially in Mongolia, people tend to favor more the hospital and second and the third stage care unit rather than primary healthcare units. And there is also, the mindset shift which needs to happen. In order to do that, we need more continuous campaign to increase awareness and also highlight that, by going into the hospital, you're exposing yourself to more risks of, infection, basically. So as I said, we need a whole of a government approach, and from political economy perspective, while a Ministry of Health plays an important role, we need like coordinated approach, including Ministry of Finance and also a behavioral and psychological study-based communication campaigns to focus more on primary healthcare. That is as the report shows, very important part of the solution. Thank you.
Thank you very much, Vice Minister Kulan. If I can turn briefly to you, Mr. Budi, again, you mentioned this PKG program of screening for NCDs, cancers, and even mental health. Could you tell me a little bit more about how this program has performed, and also when you detected problems and diagnosis, what kind of follow-up management has happened, and how much does that need to improve?
So the program launched 10th of February last year. And to be honest, our focus is just to launch the screening side, not the treatment side yet. So the screening side by December, 31st December, it reached 70 million screening. Our target this year, it will be increased from 70 million to 140 million. And this year, we will start the treatment. So if you hypertension, 120/80, you're okay. Below 140/90, you are yellow. Above 140/90, you are red. It will appear on your individual apps. So when you are red, then we will give you a treatment. Every day, amlodipine, you have to take it. In a month after that, you will be another hypertension test. So this is, we just do a pilot project, and it's only 3%. So we have a lot of upside, because 6 million hypertension we found, only 3% is controlled. So this is something that we would like to accelerate this year. But I would like to share with you all what important in this screening program is for 4 biggest non-communicable diseases: burden, heart disease, stroke, cancer, and kidney. Our strategy is single and simple. Detect early, treat early. Because we believe if we can detect early and treat early, not only the cost will be significantly less, but also the quality of life of the people should be better. What I need a help from World Bank. If you have a good health economics, help me to identify the cost difference in the 5-year cycle of people that have controlled diabetes or uncontrolled diabetes. Because this year we will start with the treatment. If we have the diabetes, HbA1c is about 6.5 in diabetes, and we give them metformin and they become controlled, and the other group, it is uncontrolled, what are the overall health cost difference? My feeling, it will be between 5 times to 10 times. So can you imagine? You get stroke, you have to send them to the hospital, do CT scan, thrombolysis, thrombectomy, maybe craniotomy. The cost, I think, is easily 10 times more expensive rather than you keep it in the primary care and give them metformin every day. So if that is, I need your help to calculate the difference of health costs for control and non-control. My feeling is 5 times to 10 times. So we can get 50% discount or up until 90% discount of overall health cost expenditure if we do this screening at the primary care properly. And if you are talking about 40 billion health costs every year in Indonesia, you are talking about 20 billion to 30 billion saving. So that will be very, very significant. So that is, I need help from World Bank to calculate, this 5 years cycle cost.
I think this homework, my colleague Karen there, Feng there, and Ronald, so you are accountable. you have to deliver, and overseen by, of course, Carrie. So, Beverly, you've sat here patiently listening to all these people talk about healthcare. When you are a protagonist, you are the private sector, and our institution and Indonesia is looking increasingly to the private sector to help deliver better primary health care. But we have this curious situation. In urban areas, you have possibly adequate facilities, but no consumers. And in rural areas, you don't have any options, but inadequate supply. So what is the private sector doing, alone or in partnership, to try and bridge these gaps between demand and supply?
Yes, good morning, everyone. Maybe the way to look at it.
Two, I need to use my powerful pen to write a regulation. They are not abusive. So that is the other thing. I write a regulation so easier for them to invest instead of me using their own balance sheet and capital, build a primary care and secondary care, and then make them sustainable so they earn decent money. Number two, put that cap so they are not abusive. So that is always my philosophy. That's why now the private sector company come in. Now, how do we control the quality and the price, like what he said? That's why I need the person who just left. He is the head of the Indonesian National Health Life Insurance Company. Not life, health insurance company. National Health Insurance Company. He's being hated by many doctors, many primary clinics, and many hospitals because he is the one, a single, very powerful payer that can control the healthcare providers. Why he is so powerful? Because his job is to push back the supplier of the healthcare services so not to be abusive in terms of pricing. So I told him, if every healthcare suppliers love you and praise for you, you are a total failure because you are not doing your job. If all healthcare providers doesn't want to sign up with you, you are also a total failure because the system breaks down. But if all hospitals, all primary healthcare clinics, or pharmacists would like to engage with you, but every day they are yelling at you because you are negotiating, the price is so cheap, you don't pay enough the doctors are complaining to you, then you are doing an excellent job. Because your job is to give a pushback. Otherwise the healthcare costs will basically increase. His job also to make sure the quality of the value of the care that is given is also meeting your standard. Otherwise, you again discount the reimbursement that you gave to that hospital. So he plays a very significant role to control the price and control the quality. That's why I said I want him to get bigger and cover, 60% of the overall national healthcare expenditure. Now he is only covering 30%. Out of pocket, private insurance, companies are still paying it. I would like to increase his portion from 30 to 60 and let the private insurance get 20. This is the only part when I would like to keep private insurance smaller than the government insurance. In the facilities, I will let the private get bigger, use their own capital. Why? Because when the private insurance is bigger, something like United States will happen. They start building a coalitions, for-profit coalition with the hospital, for-profit coalition with the doctors, and then they increase the premiums. So at the end of the day, the government and the people suffer because they are on business motive. So again, what I will do, dominating the payment side, let the supplying side, the capital side built by private sector, but the payment side controlled by the government for quality and price, 60%, and then to make sure that enough efficiency, innovation, etc., put the private life insurance by 20%, so 80% to 90% of the payment is controlled by an insurance company, not out of the pocket. Thank you.
I think that's a very nice point. I think in your opening statement, you also talked about this puzzle of the persistence of price differences for example, standardized procedures like knee replacements and hip replacements. I think this creates also the puzzle why insurance companies and private providers, whether knowingly or unwittingly, inhibit trade in healthcare services, where there are big cost savings.
By the way, to say, more Australian now coming to Indonesia, at least for aesthetic treatment, laser, Botox.
Because it's not covered by insurance.
Yeah, it's not covered by insurance.
Exactly.
And it's cheaper to do it in Indonesia or tooth.
That's dental. Or there are long waiting lines in England. But turning to you, Vice Minister Kulan, Mongolia is one of the early adopters of capitation payments to primary health care in the region. And you recently actually increased these capitation payments. But how are you ensuring value for money? Are there monitoring and incentive mechanisms in place to hold providers accountable?
Thank you for your question. So indeed, Mongolia recently adopted a blended payment model in which 80% of the primary healthcare funding is distributed through capitation payments, and 20% is allocated based on performance indicators. So by blending, the performance indicators include, for example, vaccination coverage, prenatal visits, hypertension control, diabetes screening, cancer screening, or referral quality, post-referral follow-up, and home visit coverages. So those are the, within this 20%, those are the KPIs we try and monitor. So also the geographic, because Mongolia is very unique in a sense that we are geographically very dispersed. So half the population live in the capital city, but the rest of the population live really far away and very dispersed, right? And many of them are nomadic families, which means, they don't stay in one place throughout the year. They move at least 4 times a year. So this is the uniqueness of Mongolian situation in terms of, inclusive and accessible primary healthcare. Taking into account of that, we do geographic adjustment coefficients, and these are embedded in the capitation formula to ensure that the remote providers receive adequate funding despite higher operating costs, because they have to reach to the patients and provide the healthcare services, and which is very different compared to what we do in the city. And also, the budget law defines healthcare sector performance indicators, which includes, targets to increase preventive care spending and reduce out-of-pocket payments, which allows, Ministry of Finance to link funding allocations to measurable results. When it comes to out-of-pocket spending, I think it's a 34. More than 30% in Mongolia, as highlighted in the report, which is above the the global or regional average. So we really have to focus on this part going forward and apply whole of a government approach in ensuring that out-of-pocket costs are being reduced, basically.
Thank you very much, Vice Minister Kulan. If I can turn to Secretary Shri, the report talks about financing models that incentivize performance, but that requires, significant public financial management reforms. So how far are such reforms feasible in small island states such as Fiji? And are you thinking in these terms?
Thank you very much. In terms of PFM reforms in the region, I mean, relative to other Pacific Island countries, Fiji is slightly in a better position given the capacity that we have in Fiji, including the support that we get from development partners for PFM reforms, including from World Bank. However, in terms of performance-based focus, at the moment, all our funding allocations generally in the health sector is very much focused on the inputs, including KPIs largely focused on spending and the input side. However, there's a need to focus on performance and outcomes, as we discussed, especially some of the discussions that we have had on primary healthcare and the outcome-based focus. And we are starting this reform. Again, as I said, that's slightly challenging, but given the capacity support that we have from development partners, we are going to embark on that, starting with the health sector. It would be a journey for us, but at least the thinking is there, the political buy-in is there, and the support from partners are there. Thank you.
Very much. Beverly, this viability of prevention, what kind of imaginative policies do you think would make prevention financially and politically viable? And, this whole idea of capitation, performance-based, based on long-term health outcomes, between the idea and the practice falls a big shadow. How can you bridge that gap?
Well, in general, preventive services are what we would call low margin services. But then it makes sense to do it because you're supposed to have volume, right? I think with that as the base, maybe my ideal primary care payment mechanism would definitely have to be something wherein there's a big empanelment size that's already pre-assigned to a certain provider that allows them to sort of predict how many people they need to give services to, how they design their entire system to. But second also is, can government pay in terms of outputs and outcomes? And that is probably not going to be in one go that they're going to be paying for outcomes, because for sure the providers are going to ask what is included in that, right? And when we talk about comprehensive health services that typically a public health center carries with it, it's very different from how a private sector would look at each service component usually in a fee-for-service design. So, and then the last point is how make sure that the barrier to entry for being contracted as a primary care provider is low enough, but allows certain proxies for quality. And I say this because there's this fancy for one-stop shop services. And what I've been seeing at least in many countries that we've looked at is, at the end of the day, the most important component of primary care service is the people, not just the patient, but the actual healthcare provider who's rendering the service. But if we're stuck with having to do a one-stop shop, we're forcing the primary care provider whose competency not really lies in running a lab or running a pharmacy to to build out a facility and give everything, right? So for me, it raises a lot of questions around, among the different services within primary preventive care, what is the most important? And that means, what should the accreditors, the people who accredit you for being a service provider, really needs to look at? And what are the other things that can just be added at the end of the day? Because when we're able to open up to as many more primary care providers, meaning physicians, nurses, etc., then I think that's the most organic way to grow the primary care system. And it's not looking at big corporations who have multiple clinics, etc. That's the supporting cast for me, for primary care. The primary cast are primary care physicians, nurses, community health workers. If we're able to get them to be the main actors in moving this system, then I think that would be the sustainable path to the future.
Thank you, Beverly. If I can just turn to Rosemary for a brief response to a last question. You know, we are thinking of you as a donor, but Australia itself has very unique health challenges. You have a large, rural, very dispersed population. You have the First Nations people who have unique, healthcare preferences. So what are the lessons that we would learn from how Australia is improving services to deal with non-communicable diseases, and how might they inform, what you are doing in, say, the Pacific Island countries?
Thank you. So that's a really good question. And Australia's own experience does offer many useful lessons, but as the flagship report stresses, all reform must be sensitive to local contexts, and what is successful in Australia needs to be adapted. But one key issue that we have learnt is, in addressing inequities in health, the real importance of working with communities in the development, delivery and evaluation of services. And this is really true, for example, in terms of addressing the gap in health outcomes with Australia's Aboriginal and Torres Strait Islander communities. We've really had great success with use of the Aboriginal community-controlled health organisations and also the Aboriginal and Torres Strait Islander health workforce, which has really demonstrated the power of culturally grounded, community-led primary health care based in trust, community connection, but also supported by national training and registration. And that's an area in which we are sharing our lessons, mutual sharing of lessons in the Pacific with Vanuatu, looking at how this might be relevant to their own health worker program. I also just wanted to highlight the critical importance of investing in prevention. I know that's been a really big theme of the talk today. It's certainly something that Australia has really demonstrated can have huge health impacts through the work that we've done on tobacco prevention over many years. Pioneering comprehensive measures including plain packaging, high taxation, smoke-free laws, effective public health campaigns, and more recently looking at new techniques such as vaping. And this has really reduced smoking rates, improved health outcomes, and reduced the financial burden on Australia's health system. An organisation such as the Australian McCabe Centre for Law and Cancer is sharing this expertise with the region. And I think we're probably at time, but I won't go into details, but I'll just say that another area where we are really taking our experience to the region is in our approach to eliminate cervical cancer, which really has lessons in terms of use of evidence-based approaches, new technologies, utilising the HPV vaccine and new screening tests, and taking innovative approaches such as mobile clinics to ensure that women who may not previously have got access due to disadvantage or distance can now access treatment. So I'll finish there, but yeah, lots of cross-learning. Thank you.
Our brilliant panel for the fantastic, insightful communication. You know, we have an online audience of over 400 people, and I'm really grateful to all of you for having come here. And it's been a pleasure. This conversation could have gone on for a long time, but Prime Minister has to go and attend another meeting. So I will liberate you. But thank you so much for making this such a scintillating event from your participation and your presence. Thank you so much. And before we move to the concluding thing, I think I'll say goodbye to you. It's a pleasure. Thank you. Thank you very much.
Pada Pak Budi, kita foto dulu sebentar, mohon. Dan kami juga akan mengundang, we would like. Okay, first with the panelists. Ya, silahkan dulu kita foto bertiga. Ya, the three of you. Okay, thank you. Ms. Beverly, please return to your seat. And we would like to invite Ronald Mutasa, Erin Sowers, Akash Zelalem. We are going to have 2 sessions, a photo session. Yeah. Oke, silakan fotografer. Okay, thank you. And the second session, we would like to also invite Feng Zhou. Sudah ada? Not yet? Bapak Pandu Harimurti, Patrick Mueller, Christina Sukumawati. All complete? Okay. Okay, thank you very much. Give a warm applause. Thank you very much. Terima kasih Bapak Menteri. Kami persilahkan untuk meninggalkan ruangan untuk menunaikan tugas berikutnya. Thank you for coming, attending this event. Ladies and gentlemen, the program will continue as scheduled, and we invite all participants to remain with us for the next session. Masih ada acara yang akan dilanjutkan. Kami persilahkan untuk kembali duduk. We would like to invite all participants to remain with us for the next session. And we would like to thank all the panelists via Zoom, the virtual panelists. You may leave the room. And we will continue our next program. Ladies and gentlemen, we invite you to return to your seat as we are going to continue our next program. And we approach the conclusion of today's program. We will hear a forward-looking perspective and closing remarks. Please welcome Ms. Karen Bredenkamp, Practice Manager, Health, Nutrition, and Population, East Asia and Pacific, the World Bank.
Thank you, and thank you again to our panelists for such a rich and insightful discussion. I have to say that your reflections truly brought to life the key messages of the Healthy Future Report. And that is that our countries in the region, in East Asia and Pacific, face a rising tide of non-communicable diseases. And primary health care, and specifically a reimagined, renewed, revitalized, and re-energized primary healthcare system is going to be at the heart of the response. Primary healthcare needs to refocus. Primary healthcare needs to focus on prevention, detection, continuity of care, strengthening referral linkages, be digitally enabled, and sufficiently financed. And you know what? When it does that, the payoff is immense. Better outcomes, lower overall costs, and more equitable access. And friends, in East Asia and Pacific, as we've heard here today, this transformation of the primary healthcare system is already underway. And at the World Bank, we are partnering with many countries to invest more and also to invest better in primary healthcare. Here in Indonesia, we have been working with Minister Budi and his team, as you have heard today, on what must surely be one of the most ambitious and transformational health agendas globally, with the modernization of primary healthcare, with provider payment reforms and digital innovations to strengthen community and local responses in the form of primary healthcare. And in the Pacific Islands, where we have an extremely high NCD burden, as the report shows, but also where the primary healthcare agenda is inseparable from the realities of geography and of climate vulnerability, the World Bank Group is supporting Fiji, Kiribati, Tonga, and Tuvalu to build regional primary healthcare networks, strengthening screening and diagnostic capacity, expand digital and telemedicine responses that can together ensure that even the most remote and outer-lying islands can have timely access to continuous care. In Cambodia, we are supporting the government to expand financial protection through health equity funds and scale up NCD screening and diagnostics right across the country. And in the Philippines, we are supporting the creation of integrated primary healthcare networks, which also have upgraded and digitally enabled health facilities to build a much more resilient foundation for routine services as well as for emergency responses. These are just a few examples, but I think that they are illustrative of the fact that regardless of context, investing in primary health care is imperative. Looking ahead, we at the World Bank Group are going to build on the findings of this report and also the great momentum that we have as a result of this launch here today through many different country-specific engagements. Our teams are going to work a lot more closely with ministries of health and finance on technical work. We are going to support governments on changes to policies and practice of primary health care, and we are going to expand our financing to both the public and the private sectors to help build primary health care models that meet the needs of today and the needs of tomorrow. Friends, this report is a call to action. It's a call to action for governments, for public and private healthcare providers, and for development partners. At the World Bank, we are ready to take this action, and we are really looking forward to working with all of you to transform this vision of a healthy future into a reality for all the people of East Asia and Pacific. Thank you.
Thank you, Ms. Bredenkamp, for the closing remarks. And for the second closing remarks will be delivered by Mr. Alberto Rodriguez, Director for People, East Asia and Pacific Region, the World Bank, who joined us virtually. Mr. Rodriguez, the stage is yours.
Thank you very much. I hope that you can hear me. I'm joining from Washington, D.C. It's been a tremendous privilege to be part of the audience, really, of this event. I think that the reflections that we've heard from the panelists, the presentation made by the authors, has really been, at least for me, quite informative. And they illustrate the work that the World Bank is doing, but really the work that the governments are doing and that we support. I'd like to thank also the government of Indonesia for welcoming us this morning in this event. And also I want to send my thanks to the government of Australia for co-financing this work and also for a very broad collaboration that we have together in the health sector. I just want to say that of all the lessons and all the things that have been discussed, one of the takeaways that I really find very insightful is that yes, primary healthcare is extremely important because it has enormous returns, and it is true that it means catching conditions early, not late, ensuring that clinics have diagnostic mechanisms, medicines, digital tools, trained workers, etc. But I think that Minister Budi made a very strong point around the issue of behavior change. This is really at the heart of prevention. How can we get folks to be more concerned about health, concerned about behaviors? And I think that this is something that we need to reflect because there are similarities around the world with other issues. For example, the issue of nutrition, where behavior change plays a critical role in really changing the profile of the issue and responding to it. I just want to say that from the World Bank perspective, as Karen just said, we are committed to moving forward with this report, to really supporting governments that want to invest and make significant changes by focusing on primary healthcare. And that usually what I see around the world is that countries look to East Asia as the precursor, as the country that always, the area of the world, the region of the world that is always in the lead with new approaches and with tackling the issues that other regions will suffer in a few years. So you all have a strong responsibility. We are watching you, we are supporting you, and we look forward to together working to fight this NCD epidemic and really tackling the difficult issues that it brings to East Asia and the Pacific, and that it will bring in other regions of the country, of the world in the next few years. Thank you again. Have a wonderful day, and it's been a great pleasure to hear all of you in this discussion. Over to you.
At this point, we will be concluding the Zoom participation. Once again, thank you for your participation and engagement towards this event. The program will continue on site as scheduled. Once again, to all online participants, thank you for your time and engagement. We wish you a pleasant day. Ladies and gentlemen, we will now continue with the